Good evening and welcome to this wrap-up interview. I'm Adnan Kastrati, and it's a pleasure for me to co-chair this interview with Antonio Colombo here. We have three renowned interventional cardiologists: Dr. James Flaherty from Northwestern University in Chicago. We have Alexandra Lansky from Yale School of Medicine in New Haven, and Kevin Bainey, Alberta Heart Institute, Edmonton, Canada. So let's start. We have a few questions about complex PCI, and we are excited to know the answers from the participants here. So let's start with the first question, and I would like to have the answer from Dr. Colombo. How can we succinctly define complex PCI before going to deal with this subject? Is it defined by the time required to perform it, by the specificity of the technology and techniques to be used, or by the risk of complications? Antonio?
But I think I will took the Gennaro Giustino definition with some modification. This definition been published in JACC, first author is Gennaro Giustino. I would say that to me complex PCI is a PCI where you have to use a support device, balloon pump or impeller. Is a PCI where you have to use by intention to treat or at the beginning of the procedure because of balloon does not cross rotational or some other form of atherectomy. Is a PCI where you have to deal with a bifurcation where you need to implant two stents or even one stent, but you need to cross into the side branch and dilate the side branch, where you have to use long stents, you can say longer than 30 or 35, and when you have to place more than 3 stents in general. Of course, this is a priori definition, and then there is also a complex PCI that starts simple and becomes complex, but I think I will stick to the a priori definition.
Kevin, do you think that only lesion characteristics are needed to define a complex, or also patient characteristics are impacting on this characterization?
Yeah, it's a great question. I think we oftentimes are too focused on lesion characteristics and often ignore the patient. As you know, elderly patients, I find, can fall into the complex PCI category simply because of tortuosity, access, especially when going radial, dealing with tortuosity in the subclavian. So I first think that age meets that patient criteria. The other patient criteria that leads towards complex PCI are hemodialysis patients or patients with chronic renal failure, where you're dealing with a lot of coronary calcification. And the third group that we're doing more and more complex PCI on are those patients with aortic stenosis that fall into the moderate to severe range, where your PCI gets complicated because of the hemodynamic instability that can occur often with concomitant aortic stenosis. And then the fourth patient population, I would say, would be diabetic simply because of the instant restenosis risk.
Yeah, thank you. Alexandra, we have now a class 1 indication for intravascular imaging or PCI, but I'm sure that not everyone is using it, not in 100% of the cases. But do you think that for complex PCI, we need 100% use of intravascular imaging?
Absolutely. You're right. I think invasive imaging is not used enough. It's well below 20% overall. But I think particularly in high-risk PCI, left main interventions, we should be using it in absolutely everyone. There are randomized clinical studies that demonstrate the benefit, the clinical benefit. We have just looked at our own series from the PROTECT 3 clinical study. These are Impella-supported patients. About 1,000 patients. This is real-world patients, truly complex and high-risk patients. About 50% of those patients had invasive imaging, and I can tell you that MACE at 90 days was reduced by 30% overall. And then when you look at the patients with left main disease, MACE was reduced by 40% and mortality reduced by 40%. So, I think as you go to more and more complex patients and high-risk patients, I don't think those are exactly the same. The benefit of invasive imaging is absolute, and I think, yes, in 100% of patients, we should be using it.
James, you heard Antonio mentioning mechanical circulatory support in patients having complex PCI. In which category of patients you are not allowed to start the PCI, the complex PCI, without having mechanical circulatory support?
Well,
what do you think?
Thanks for that complicated question. I think that there's a number of factors that inform that decision. It's not just LV ejection fraction. It's other things like blood pressure and filling pressures and cardiac output, and whether the patient is in active heart failure or acute coronary syndrome. Do they have valvular heart disease, pulmonary hypertension? There's a lot of other things that go into that decision. And then it comes down to the complexity of the intervention that's being proposed. Syntax score is a tool that's used. Is it going to require tools like atherectomy or lithotripsy, complex left main bifurcation, so CTOs, especially with the retrograde approach. So really there are some scores that help you make that decision, but there's not a particular case where you say that definitely does or doesn't. It's the whole constellation of the patient and the procedure being performed.
So you think that you should have it available in any case, just to have it in the cath lab?
Absolutely. It's mandatory to have the tools like balloon pump and we have Impella available, even ECMO in some cases.
Because you know that many complex procedures are done in small centers without having this. And that's why we have to highlight this need.
Well, and one of the big focuses is on completeness of revascularization. If you don't have the tools to do it, you may have to break a procedure into multiple sessions rather than try to accomplish everything at once. Because when you do the longer, more complex procedures in one setting, you introduce more risk.
Alexandra, a very difficult question. So if you have to choose one of the specialty techniques, ablative or high pressure balloons, or very high pressure balloons, or scoring balloons, for crossable lesions, we are not talking about non-crossable lesions because for that it's clear. What should have been one of them that is indispensable for you in the cath lab?
And price is not an issue.
No.
If price is not an issue,
No.
I would say IVL would be the choice. I think we need to evolve with time. Atherectomy devices have been there for a long time. I think, in certain non-crossable lesions, obviously, we will still need atherectomy. But I think for the most part, IVL has turned into a device that is, very user-friendly across many, operators. And the complication rates are lower. The clinical benefits have been demonstrated and are there. So I think that, in my mind, would be the one device. Again, if cost is not an issue.
Yeah, I think that the cost is not an issue to discuss because there are regional variations in the cost. There are regional variations in the reimbursement strategy. So you cannot have one recommendation for everyone. And the last question to discuss about us here is what is the role of DCB in complex PCI? Do you see a major role in the future of DCB, or should we stick with our conventional device, stent?
I think that at this meeting, we're certainly seeing an increasing role for DCB. I'll take a step back, and I vividly remember being at a meeting, live case, and it was Antonio Colombo that was using DCB, and I believe it was a left main case. and my jaw dropped, leaving it as DCB result. And it had me think about really the utility of a DCB versus a metallic stent. And that really opened the eyes to many interventional cardiologists. And now we're seeing the emerging data to potentially support the use of DCB in this arena. And perhaps it will reduce the risk of restenosis. I think over time we'll tell from ongoing RCTs in this arena, but certainly very provocative.
Alexandra, what do you think?
Well, I think we need to be careful. I don't think all lesions should be treated with DCBs. We're very focused nowadays on in-stent restenosis, small vessels, and not to say that that's where we need to stay. Bifurcations, I think, are clearly with the side branch in provisional stenting. I would be very wary in highly calcified lesions. That's not a good place to be using a DCB in my mind. And I don't know that I would do the left main with a DCB. But Antonio, you're the guru here.
No, but I think what has been said is perfectly correct. Why to use a DCB instead of a stent? The stent has 20 years of data with tremendous safety and not 100% free of MACE, but very low MACE. So I think we have to use DCB in areas where stents do not perform very well, where we can simplify the procedure, as we discussed half an hour ago, to avoid full metal jacket of the LED. I don't personally like very much. I believe that is important, but I have reservation to do a trial of stents versus DCB. The two devices are complementary nowadays.
Mm-hmm.
I would love to do a trial in a cath lab, I was telling Adnan, where for the first 6 months you don't have DCB. For the next 6 months you have DCB in the cath lab.
Yeah.
And compare, we have the same operator, the same type of patients, and you see how the real life makes you make decisions and what this decision has an impact on the outcome.
Yeah, sure, you are right for that. But on the other side, what we have now different in comparison with the time of PCI with balloon angioplasty is the better lesion preparation technology.
Lesion preparation to evaluate the result, etc. One point to go back to what has been said, I think has been mentioned the value of measuring the end diastolic pressure. In Europe, we rarely do right heart catheterization. A surrogate could be to measure the end diastolic pressure crossing the aortic valve, but you have a patient that you are not so sure, the ejection fraction low is a bad point, but I will be very, very scared to do a procedure in a patient who has a 40 millimeter of end diastolic pressure.
Mm-hmm. Mm-hmm.
James, I know that in the US there is less experience with DCB. And so for complex PCI, even less. So what do you think?
We've had it for less than a year, but prior to last year, we were actually using the peripheral balloon whenever we could. I think it came in 4.0 in larger sizes, but you could undersize it and do left mains or proximal vessels. But it's finding its place. It's certainly an indispensable tool for restenotic lesions. I think everyone would agree on that. Mm-hmm. There's no need to put an extra layer of metal down just to get drug. But I think we'll see the emergence of ways Dr. Colombo is alluding to as a stent sparing strategy, where you don't need metal throughout the whole coronary tree to get an effective treatment. You have imaging, you have other tools. So I think it will lead to less total stent need, and that'll be a good thing.
We've had a bit more experience with drug-eluting balloons in Canada. We've had it for a while. And you know, where we find it very effective is small vessel disease. I do worry about, you know, these 2.0 stents that we're putting in the ISR risk. In fact, I've gotten rid of the 2.0225 stents in the cath lab because of that ISR risk, and we've just simply gone with drug-eluting balloons to avoid that full metal jacket. And the other emerging use of DCB, at least in Canada, is side branch strategy, where, you know, you have, you know, TIMI 3 flow down a side branch, but the ostium is pinched, and normally we just use a regular balloon and end off with a kiss. Now we're using a DCB in that arena, and we hope that side branch will stay open with the DCB. But those are the two applications that we're using it, and of course for in-stent restenosis, albeit I'm not convinced about the DCB versus DES. But if you've had 2 DES and ISR, then yeah, we'll use the DCB.
Yeah, thanks.
Can I ask a question? What is your imagination about the role of DCB if you had available a reliable bioresorbable scaffold?
Yeah. You know, maybe I'll take that question first. We were using Absorb when it was available, and actually had good results with it until it got taken off the shelf. And, you know, I do think that in the future, I think that there will be a role for bioabsorbable scaffold, but right now we don't have it. And so the alternative is a DCB.
In my opinion, even with a bioresorbable scaffold, there would be a role for DCB. And I project 3 or 4 years from now a metal-free PCI, not 100%, but in a certain amount of patients.
Antonio, you think that DCB are discouraging the efforts in bioresorbable scaffold technology?
I don't think should, but that's the reason why we should not look at the two technologies as antagonistic. They are working in the same, for the same goal, to limit the foreign body, to limit, not to make it disappear. We know that patients with a short 20 millimeter 3.5 stents on the right corner proximal LAD do very well. We did the 10 years follow-up on those patients. But the total situation is different. Can you imagine when we did the Syntax trial, we implanted 7, 8, 9 stents on some patients. That is unacceptable. And we still use those data for our guidelines.
Yeah. I do wonder about the use of imaging when considering a DCB. You know, practically speaking, at least with our use in Canada, is that you do have to get a stent-like result with preparing the lesion before you end off with a DCB. But what is the role of intracoronary imaging to make sure that you have that stent-like result before you end off with a DCB? It's a big question in my mind.
It's almost like a lifetime management question. Yeah. You know, there's only so many stents you could put in a heart.
Yeah.
But, you know, but if you want, you know, I see a lot of patients go later to CABG because the clinician says there's too many stents in.
Yeah.
Now it's time for surgery.
Yeah.
But
in my database, there are patients who have had 8 layers of stents.
Yeah.
8.
Yeah.
8.
Yeah, I have patients with 6, 7 layers of stent. We go back to the history. Victor stent, Jan Turco, Rubin, Cypher, Daxus.
That's
Wow.
So, Antonio, would you like to make a few conclusive remarks about
But I
complex
think,
PCI?
I think complex lesions should be taken seriously, but even simple lesions should be taken seriously. I don't like when the operator says this is going to be a simple PCI, because we saw some simple PCI becoming a terrible PCI. So I think in this time period, we are really low on complication. And especially in calcified lesion, thanks to what Alexandra said, we have lithotripsy, we have new devices that make this subset a very safe area. Rotablator is important, but we know that young operators don't have a lot of experience and sometimes they get complications. You need to know how to use it, but I think complex lesions should carry safety. That's my message.
Thank you very much, and thank you all for this lively discussion and the very good points we have made.
Thank you.
Thank you. Good evening.
Thank you.
Thank you.